Our first live webinar, being streamed across the globe, is from Sydney, Australia, with Professor Cheryl Jones talking about Enterovirus Encephalitis.
So my name is Cheryl Jones. I'm a paediatrician and infectious disease specialist from Sydney, Australia, and I'm going to tell you tonight about Enterovirus Encephalitis. Some of the things I want to talk to you about are, what are enteroviruses? How do they spread? Who is at risk of getting these infections? Tell you a little bit about, is there any treatment or prevention for enterovirus infections? And then tell you about enterovirus encephalitis specifically. What is it? How common is it? Who is at risk? What are the long-term effects? And then tell you about some of the epidemics that have been happening around the world, including in Sydney, Australia. So what are enteroviruses? They are very small RNA viruses, ribonucleic acid viruses. They don't have an envelope. We classify them into two broad classes. One of them, polioviruses, which commonly causes polio. The other are the non-polio viruses, and these are things like Coxsackie viruses, echoviruses, and the numbered human enteroviruses. These include human enterovirus 71 and human enterovirus D68, which has caused disease recently in the United States. How do enteroviruses spread? Enteroviruses are shed in secretions of infected people, particularly their feces, their respiratory secretions such as their cough, sputum, nasal secretions, so that people can spread them by having fecal-oral transmission, by contacting respiratory secretions transmitted by droplet spread, either on their hands or a contaminated environment. Occasionally, it can transmit through contaminated environments such as the water. Sometimes mothers who have enterovirus infection in late pregnancy can also pass it on to their baby around the time of delivery, so their baby has quite a severe enterovirus disease in the first weeks of life. When do enteroviruses occur, and who is at risk of these infections? Enteroviruses commonly occur in the hotter, warmer months of the year. The attack rate, or the people who are most susceptible to these infections, appear to be young children, especially those less than 5. But enterovirus infections can occur at any age. Risk factors that we say are associated with enterovirus infections are things such as poor sanitation in the environment or crowded living environments. Age, as I mentioned, particularly young age, less than 5, and also problems with your immune system, particularly your T-cell immunity, can make you more susceptible to a chronic enterovirus infection. So what should clinicians or family look for? It's important to mention that the majority of enterovirus infections are silent. They don't cause any disease. Then in some people, they may have a short-lived febrile illness. This could be associated with a sore throat, with diarrhea or vomiting, abdominal pain, and sometimes a rash. The classic rash associated with enterovirus infections is something called hand, foot, and mouth disease, with little blisters at each of these sites. Occasionally, enteroviruses can have very serious complications involving the lungs, the heart, and the nervous system. In the nervous system, if they involve the lining of the brain, this is called meningitis. If it involves the spinal cord, it's called myelitis. Or if it involves the brain itself, it's encephalitis. And you can get a combination of all of these sites. When the nervous system is involved, you may get that preceding fever and rash, but then you may get more serious symptoms such as headache, neck stiffness, lethargy, altered conscious state, confusion, abnormal movements, clumsiness, problems with your speech or balance. The recent outbreak of enterovirus D68 in the United States had episodes of respiratory illness associated with acute flaccid paralysis, so floppy limbs like classic polio. This was with or without fever. So how does your doctor diagnose enterovirus infections? Well, they may simply do it by the knowledge of the symptoms that you present with, particularly if it's in a young child, or you've been known to be exposed to someone who's had an infection, or they're aware of outbreaks in your community. They can confirm this infection in the laboratory by analysing secretions, either the faeces or respiratory secretions, for the genetic material of the virus using a test called PCR, or polymerase chain reaction. There's also more traditional methods, trying to culture the virus in the laboratory or measuring your immune response to the virus in the past, something called serology. When someone has an enterovirus infection of the nervous system, we may do other tests to see if the brain has been involved, things such as imaging of the brain through MRI or magnetic resonance imaging. We also look for the virus and for inflammation in the spinal fluid, the cerebrospinal fluid. Is there any treatment of enterovirus infections? Unfortunately, at this time, there is no effective antiviral therapy for enteroviruses. Treatment consists of supportive measures for fever or pain, bearing in mind not to give aspirin to febrile children with a viral illness, but also intensive care therapies such as supporting the breathing or blood pressure. How do we prevent enterovirus infections? They can be very difficult to prevent because people are often unaware they've had the infection. But when an outbreak does occur, careful attention to hand and personal hygiene can limit outbreaks, particularly after contact with secretions from infected individuals. The World Health Organization has given us guidelines for preventing the spread of hand, foot and mouth disease, including establishing and strengthening surveillance, education campaigns on hygiene, sanitation, strengthening infection control measures in community and healthcare, improving clinical case management services, and importantly, like we're doing tonight, exchanging information about the infection. Are there any vaccines against enterovirus? There are some in development, particularly against human enterovirus type 71. There's been some recent publications of candidate vaccines against HEV71, which are all inactivated vaccines against a particular genotype C4. This does provide some hope for the future, but what we don't know yet is whether this particular vaccine will work against the other virus strains circulating in our community. I'm now going to switch to talk a little bit about Enterovirus encephalitis. Enterovirus encephalitis is an uncommon but very serious complication of enterovirus infection. In terms of all encephalitis infections, a study from our colleagues in the United States, Carol Glasser and colleagues, suggests that it's about 5% of all encephalitis cases. Enterovirus encephalitis typically occurs in the young, and in her series, only 27% were above 18 years of age. Generally, it's said to be a milder cause of encephalitis, with the exception of human enterovirus 71. Since 2013 in Australia, we've been conducting nationwide surveillance for encephalitis, the Australian Childhood Encephalitis Study. In our series of children to 14 years, about 15% of all enterovirus cases presenting to the Tertiary Children's Hospital were due to enterovirus infection. In fact, it was our commonest cause of infectious encephalitis. I'm going to tell you now particularly about Enterovirus 71 encephalitis. The reason is that this is a very serious disease with outbreaks occurring around the world, particularly associated with sometimes hand, foot and mouth disease, but more importantly, serious neurological disease like encephalitis. This is important because sometimes these can be fatal and some survivors have disabilities. Enterovirus 71 was first identified in the late 60s. Then followed a series of outbreaks around the world, particularly in Asia, Taiwan and Malaysia, and Europe. In the 1990s, large outbreaks of EV71 happened across Asia again, and were also seen in Australia. A very large epidemic occurred very recently in China, where in 2010 there were over 2 million cases and over 1,000 deaths. Ongoing activity with the World Health Organization suggests that there's still a large number of cases of enterovirus infection due to hand, foot and mouth in Southeast Asia, particularly China, but also places like Japan, Singapore, Hong Kong and Vietnam. The disease in most places appears to occur in a cycle with every 2 to 3 years with an epidemic. Importantly though, only about 25% of cases of enterovirus encephalitis in these series have been associated with classical hand, foot and mouth disease. So surveillance for hand, foot and mouth disease alone will not pick up all cases of enterovirus encephalitis. It's also important because severe and fatal EV71 cases have been those associated with neurological disease, particularly when it's followed by heart and lung involvement. What are the long-term effects of enterovirus encephalitis? Well, importantly, fatal encephalitis is less common than it used to be because of our improvement in supportive therapies. Many adults and children will survive enterovirus encephalitis with very little to no difficulties. However, some will have persistent problems in their thinking and learning, their memory, their behaviour, and many other physical symptoms such as their senses with vision, hearing and speech. There's been a recent report of the outcomes of enterovirus encephalitis in children from Taiwan. What they showed that simple neurological infections involving the lining of the brain alone had very good outcomes. If you had enterovirus infection of the brain, encephalitis, alone, 20% would have some residual problems. But when that enterovirus encephalitis was associated with heart and lung problems, as in the case that we'll present to you shortly, then about 75% of survivors would have serious long-term problems. I want to tell you a little bit about Enterovirus 71 epidemics in Australia. The first outbreaks occurred back in the 80s in the southern state Victoria and over in Western Australia in 1999 and again in Sydney in 2000. And these outbreaks of enterovirus infections were all associated with groups of children, particularly who had severe neurological disease. In early 2013, paediatricians in the north of Sydney started to detect an outbreak of febrile illnesses in children associated with severe neurological symptoms, particularly abnormal movements. It was found out that this was due to enterovirus infections, particularly Enterovirus 71. Throughout most of 2013, we had over 120 children admitted to one of the two major tertiary hospitals for children in Sydney. 4 children died from this infection and a large number had serious neurological disease. Most of these children presented with fever and lethargy, many with these abnormal movements. Only about a quarter had classical hand, foot and mouth disease. 10% of these children were admitted to intensive care, some requiring intubation and life support, like you'll hear shortly. We don't know fully the outcomes of this epidemic, but what we can tell you at the time of discharge, while about 3/4 appeared to have no symptoms at discharge, 25% had significant problems of their movement, thinking, behaviour, and some with very severe problems needing life support. There's many gaps in our knowledge about enterovirus infections and encephalitis, not only in Australia but around the world. For this reason, we've started the Australian Childhood Encephalitis Study. It started as a pilot in New South Wales in 2013, and through 2014 we rolled it out to 5 other states across the country: New South Wales, Victoria, Western Australia, Queensland and South Australia. And this is picking the most severe cases that are admitted to children's hospitals. And this has been led by my colleague, Dr. Philip Britton, who you'll hear shortly in the video. What we've found out so far is that we've had only over 100 cases of encephalitis in this time frame, and this makes encephalitis in children about 2 to 3 times more common than, say, the meningococcus bacteria. What we also need to know is about infections in adults, and to this end we're working with the Australasian Society of Infectious Diseases Encephalitis Special Interest Group, and with our colleagues, neurologists, public health physicians, microbiologists and emergency department physicians to try and increase our surveillance to adults as well. We're also working with our international colleagues through both the Encephalitis Society and the International Encephalitis Consortium, because we need to have global efforts to try and understand more about encephalitis. So what I've told you about today is that Enterovirus 71 has emerged as an important cause of severe neurological disease, including encephalitis, around the world, and this is particularly involving young children. There is an urgent need to determine what types of enterovirus are causing severe neurological disease around the globe, to test if these current EV71 vaccines will be effective at preventing these infections against other subtypes. But we also urgently need to have effective antivirals developed to treat those children who get infected. We also need to know more about children and adults and the long-term consequences of enterovirus encephalitis. To this end, we need to undertake international surveillance for the causes and consequences of encephalitis. So why do we need your help? Around the world, a lot of our community healthcare providers are not well informed about how to prevent, diagnose and treat encephalitis and to look after survivors with disability. So this is why through the Worldwide Encephalitis Day, we want to raise global awareness of encephalitis in professionals, funding agencies and the public to support children, adults and their families of survivors of encephalitis by providing advice and information. And together, in partnership, we need to conduct research so we can understand more about ways to recognise, prevent and treat encephalitis. I'm now going to introduce you to one of our brave survivors of the enterovirus encephalitis epidemic in Sydney, Hansi, and his mother, Evan. In 2013, Hansi was a previously healthy, fit 2-year-old. In early 2013, developed an illness with high fever above 40 degrees Celsius and limb jerking for a few days. He was seen at a peripheral hospital and became rapidly unwell with low blood pressure and needing ventilation support. He was then received life support and was transferred to the intensive care at the Children's Hospital at Westmead, where I work. Investigations there showed that he had enterovirus infection of his brain and particularly his brainstem. He required life support and in the intensive care for 44 days and hospital admission for over a year. We were able to discharge him home on home ventilation with the help of our respiratory team, our rehabilitation doctors and our neurologists. So I'm going to pass you over now to hear about Hansi and his mother Evan to tell their story about enterovirus encephalitis and the effects on their life.
Here this morning with Hansi here and his mother Yvonne, and they've kindly agreed to talk with us a little bit about Hansi's illness and the effect of encephalitis on their life. So Yvonne, can you remember a little bit back to when before Hansi had his illness? Can you tell us a little bit about Hansi and your family before he was unwell?
Oh yeah, Hansi's quite bubbly kid and he's really good kid. He sleep well, he never been sick.
And so do you remember when Hansi first got sick? What were you thinking at the time when he was first unwell? This kid, I believed that he have a very high tolerance when it comes with pain. He never cried. When he gets sick, he never cried. So the first thing, we went on Friday night with in the city to have a buffet with my friend. She that's her birthday, so we took Hansi there. That's the last night that I feel like he's like feeling funny. Yeah.
He's already doesn't want to eat and he's playing with his food. And we went home on Saturday morning. He's still okay.
Yeah.
he able to eat. But like on the lunchtime, we go out again for lunch with my husband, and then he throw up everything what he eat. That's the first
Right.
time he throw up. And
Yes.
he didn't have any flu yet, a fever, I mean. And then when we went home around 5:30, he only like have a little fever, like 37.8.
Yes.
And I gave him Panadol and Nurofen. And then on Saturday night, he was still okay. He was his fever was up and down, so he's kind of calling off, like he's going up to 37.1, and then when his medication is finished, he will if he needs another medication, his temperature go up again, like 38.9, like very, very high. So Sunday morning, that's the very funny thing, because he just lie down in the bed and doesn't want to eat anything. I give him milk, he doesn't want. I gave him food, he doesn't want. And then that's the Sunday night. I was thinking to bring him to the hospital myself,
Yeah.
but he went down a little bit with his fever, like 37.6, and he was still okay. And then Sunday night, that's he always keep jerking, and he always just like this, and he can't sleep. Like he only sleep for 2 hours and wake up again, and then sleep for 2 hours. So I take him to the Monday morning straight away. I take him to my GP in a local medical center.
Yeah.
And his temperature was up high, 40.
Yes.
So the GP was so worried, and she said, okay, he's on 40, you have to go to the local hospital. So he put drip on Hansi, and he said, he look okay, he look fine. We're just gonna test him with x-ray, urine and blood sugar. And one thing they see that's not look normal is his sugar. It went up high.
Yes. The doctors and you realised that something more serious was going on.
For me, I know that there's a problem with him, and they didn't really give him some sort of medication. Just we went there, just he lose weight straight away. He's very solid kid, always, you know. Straight away, on Monday morning, he looked so skinny, and he got all these not a bruises, but you know when you get cold, like you got
goosebumps.
Nah, in the skin, you can see the nerve, your nerve. That's what I see on him, and he doesn't look okay.
And they were reassuring you.
Because I keep asking I think my son in pain. And okay, mom, we just gave him Nurofen, and then we wait for another 4 hours. We gave him Panadol. I said, do you think there's any way to give him another medication? And they see him around 11 o'clock in the night time already. Like he can't breathe properly. He do like this in the bed.
Yes, heavy breathing. Yeah.
Yeah. And then he kept rolling back his eyes, you know. And I said, Doc, he doesn't look okay for me. And I said, kids with high fever, because he was already on 41, 42 temperature. And then and I said to the doctor, why only gave him Panadol and Nurofen if he is already like on a high temperature, you know? And then they said, oh, that's the only thing we can do, because we don't know what's wrong with him yet. All the tests, we still have to wait for the result to come back for that test. And I said, okay, because I know nothing at all about how they do deal with if they have the kids have a high temperature, you know. And then suddenly one doctor, that doctor already seen Hansi. She's a student doctor, and she came back, and I said, Doc, can you just sit down and look my son, because I think he's not okay. He's in pain. So she's just there, because my son is already jerking, shaking, and doing the heavy breathing, and rolling his eyes, you know. And then the doctor said, okay, we have to get the monitor. That's the first time they get the very big machine that I always saw in ICU. They took this big machine and put some lids on his thing, and numbers not okay.
No.
Totally not okay. Even he was in the paramedics bed, he's still able to talk with the doctor. So his brain was still working.
Sure.
Now I have a son that doesn't know how to talk, you know what I mean? When he went down to ICU, straight away, they have to ask emergency, they have to ask for the anesthetic doctor just to put him in sleep. And he wasn't sleeping, and I said, Doc, can I say, no, I think this is the nastiest thing that you don't want to see for your son. I said, what is it? And they said, we have to put a tube on his mouth. And I said, why? And they said, because he doesn't breathe as a normal breath, you know. And I said to them, like, can I just stay? But you wouldn't like it, because we have to put this very long tube, you know, and we don't like that one to see him going into his body. And that's the last time I seen my son wake up before they put the and that's it, the anesthetic, that's it. After that, I didn't see him wake up for a long time. Yeah. I was thinking he's quite ill, like they don't want even me to touch him, because if I like probably touch all those little tubes that already connected to him, I'm probably gonna you know. So the only thing I can touch is his head. Yeah, that's all.
What does that feel like to be a mother and not be able to?
Oh no, it's kind of devastated. Yeah.
Now, you were in ICU for quite a long time, weren't you?
Oh yeah, I was. Sorry.
No, that's all right. It's not a problem at all.
Sorry.
No, don't apologise. It's very, very scary what happened to Hansi, and very distressing to have such a sick child.
Waiting for him to wake up, that's the worst thing, you know.
Yes.
Every day, every night. I was thinking, you know, when he wake up, he just call me mama, ma, come, you know. But no. When he slowly wake up, they have to put some like a sticker pads on his eyes, because he not blinking, he just stare like that. That's so weird for me to look at my son like that, you know. And
when do you think you realised that Hansi was going to have long-term problems from his illness?
From the time that they said to me that he's not breathing by himself, he needs support from his machine.
Yeah.
And he's breathing, but very, very shallow. It doesn't help him if we just let him do it by himself. So when the doctor said that, and when I asked him, I keep saying to the doctor, is there any medication for that dog so that he could go back to as a normal kid? Look, mom, that's a lifelong situation for Hansi. When he say like that, I was crying, burst into tears. Because he say Hansi will be needing the machine for the rest of his life. Right?
So you were in hospital for over a year.
A year.
In total, and for a lot of that time it was having to adjust and learn to care for Hansi again and get new equipment and things. Can you tell us about how that's all affected your family now?
I had a really big problem getting his dad on track. When he was sick, he wasn't with me. He's the worst. When he coped very, very bad.
Yeah.
And I'm the very weak person. So if something that very touching words or whatever they tell me that really, really affect my feelings, I always cry. But that day, I don't know how the world turned upside down. I'm the strongest person I ever been with my son.
can you maybe tell us now that you're home and all these things have changed for you, and obviously Hansi's very different now.
Yeah.
What does a normal day look like for you and Hansi now? Can you talk us through what a normal day is like?
He's actually love nature, go outdoors, and he doesn't want to be stuck in the house. And unfortunately, he can't be on the dry circuit for a long time. He's especially winter time, that's making him sick, but that's not stopping me, actually. Yeah. And I try my very best. Sometimes I put him at risk, you know, because I have to tell you this, doctor or anyone that's here, one day I put him in a pool because I want to let him feel water again. Yeah. I did my best. Go outdoors, we go aquarium. I said, because that's what I promised to him, you know. Sure. Mom is not gonna treat you with disability or anything. You are still normal for me, you know. Yeah. So we will do everything what you could do. Yeah. He's on a walking frame, or sometimes he have bad days, sometimes he have good days on a walking frame. Sometimes he walk by himself in a walking frame, which is really, really amazing, because from the daytime that he only moving his toes until we do this little physio on his feet, put balls and some little trumpet that's singing. He able to move his
feet,
his toes, and until he's moving a lot, standing frame until walking frame. He did a lot of things. Seriously, this kid is amazing, you know.
And can you tell us about the different kinds of people who are helping you now with Hansi? Doctors, therapists, carers?
At home, it's really, really tough job for me, because I'm everything, slash nurse, slash doctors, slash everything, nanny, or sometimes clown.
Yep.
And think that there are people that helping me, you know. It's very, very amazing how government fund these little things to make my son happy. I get educators, I get carers at night to help me sleep, and I was able to go holiday. Actually, I just back to holiday because of my sister that she moved back to Sydney. She's living in Perth before, so she moved back in Sydney, and she's able to help me, and I was able to go holiday with the help of my mom and dad and everyone in my family, you know. These people are amazing. Because I said to myself, Hansi can't do anything, you know. I always sometimes imagining myself, because I'm a very, very young dog. I'm only 25 years old. I still want to do a lot of things with my life. Yeah. But I have to stop. You have to stop right there, Evan, because you have a disabled kid. Just forget about yourself and do first with Hansi. If he's stable enough, you know, that's it. You have, and then I started because these people are helping me. So I'm coming this year. I'm coming back, going to study online only. So hopefully I can make it.
So can you tell us a little bit about Hansi now and the kinds of things he likes doing and the things you enjoy doing with him?
He always wants to play, attention, lots of kisses and hugs to everyone, and it's the best feeling that when he wake up from the hospital, he able still to call me mama, and that's the only word that he know how to speak. Slowly he's learning to say Carrie's name, Anna, or he say nah. He say like means no. He still have this attitude. He love always going out the park. He doesn't care. Like, you know, if he will be walking in the frame, Mom, okay, time to walk in the frame. Put him in a walking frame. He seems like he said, let me go, I can do it. He walk in the walking frame. You could tell that he still want to do walking. And when he do walking, he say in his face, he's not saying anything, but in his face, more Mom, more. Even his face was so red already that he's doing a hard work. You can say in his face, more. And then he's doing, since the day one that he was in the hospital, I know he's very strong kid. I don't know how I just pray and hope that one day he's not doing silly things, self-pity or anything, because I told him, I promise him I'll be with him whatever happens. That's what I said to him.
Well, we want to really thank you so much for coming and talking with us today and sharing your story. We think you're very brave, and Hansi's very brave in dealing with this. So I just want to say thank you very much.
Thank you, Doc. Thank you.
So you've just heard from Evan and about the difficult time that she had with the diagnosis of her son Hansi and the long-term effects on their life. We're now going to take some live questions from our viewers about encephalitis. The first is actually from Australia, from Robert, and it says, what can we do to prevent getting the virus? As the virus is shed in the secretions of people who are infected, the most important thing you can do is to pay careful attention to your hand hygiene in particular when you're dealing with any infected secretions. So if you're changing a child's nappy, cleaning up some vomit, the virus itself doesn't have an envelope. So the best type of hand washing is simple soap and water. Alcohol rubs will work, but they're less effective. And this is also true in the healthcare environment setting as well. As I'd mentioned, there are vaccines in development. So in the future, we may be able to prevent the infection by vaccinating against those serious types of enterovirus, particularly enterovirus 71. The other important mechanisms for preventing the infection is to try and limit contact with infected people. So when we're aware of an outbreak of infected, particularly say in a healthcare setting or a childcare setting, that those children, for example, that have hand, foot and mouth disease should not go to the childcare at that time so they don't pass the virus on to other children there or carers. The next question comes from the UK, from Kathy, and she asks, what do you think is the biggest challenge for awareness in Australia? One of the biggest challenges we face, I think, not only in Australia but around the world, is that not only our clinicians, our community, but also our government agencies don't actually realise the size of the problem. When they think of encephalitis, they think of individual causes and actually think it's quite uncommon. But in fact, when we collectively record the number of cases and also hear about the long-term consequences, particularly the very severe consequences, such as a child like Hansi, then this is quite a significant problem that we need to tackle together. Another important problem is having clear guidelines for diagnosing the condition and managing the condition and clear access to specialist advice. To that end, together with our international colleagues, we've published guidelines in clinical infectious diseases, giving a very detailed overview of how to diagnose encephalitis, what tests to order, and advice regarding management. We've also done this at a very simple level for clinicians at the coalface in Australia, particularly because we have some unusual viral infections that are unique to our country. This is soon to be published in the Internal Medical Journal through the Australasian Society of Infectious Diseases and the neurologists, emergency department physicians and public health societies as well. The next question comes from Philip in Australia, who says, how can I tell the difference between a mild enterovirus infection and a more severe one? What are the signs? So the signs of a complicated enterovirus infection are not only that the symptoms are prolonged. So, for example, in Taiwan, they describe children who have complicated enterovirus infections as having fever for at least 3 days, but also that you get the development of these other symptoms, particularly abnormal movements like the myoclonic jerks that we saw in Sydney, or alterations in conscious state that are just sustained, or difficulty breathing, or seizures. These are particularly signs of more serious infection. Shirley from the UK has asked, is there any research into antivirals and vaccines? Yes, there is. I'd mentioned about some of the work, particularly coming out of China, about vaccines, particularly against human enterovirus and the subtype C4. There's been 3 publications just recently in the Lancet and the New England Journal of Medicine. One type of vaccine immunised over 5,000 children. It showed that preventing any sort of severe disease, the vaccine efficacy was about 80%. Another study in New England Journal of Medicine in 2014, again, immunised over 5,000 children. Here the vaccine efficacy was 95% virtually against EB, hand, foot and mouth disease, and herpes angina, which is the mouth, the sore throat infection from enterovirus. The most recent publication in the New England Journal of Medicine, again a different vaccine, but also the C4 genotype of human enterovirus 71, immunised over 6,000 children. Here the vaccine efficacy was close to 97% against EB, hand, foot and mouth disease. So there's a lot of promise. There is a lot of work around the world also trying to look at discovering new antivirals, particularly looking at surface structures of the virus and how they may interact with human cells. But at the moment, there is no antiviral agent that's licensed for use. Another question we had from the UK is from Daniel. What message would you give to other doctors about this condition? I think the message is twofold. Firstly, to be aware of the symptoms of enterovirus encephalitis, to be aware how to diagnose it. We find particularly not only do we get the virus from the spinal fluid, but also importantly, we can more reliably detect the virus in the stools and the nasal secretions. But secondly, to refer early for additional supportive measures, including not only life support as you need, but also neuroimaging and more extensive testing. The other thing is, while many children and adults will recover from this infection without any long-term problems, it's very important to connect families and children and adults into rehabilitation services with brain injury units. Sometimes survivors have no signs of problems when they're discharged from hospital, but will show subtle changes in their ability to return to work and school, their thinking, learning, and just their regular activities of daily living. So it's very important to connect people to their services. Another question we've had is from Evie from the UK, who said, what are the long-term implications of hand, foot and mouth disease, and do you always recover well? It's important to remember that hand, foot and mouth disease is nearly always an infection from which people recover. Complicated hand, foot and mouth disease where the virus has spread to the brain or the heart is uncommon. In China, it's said to be about 1 in every 1,000 cases. So most children and adults who get hand, foot and mouth disease will not have any long-term problems and will recover from the infection with no consequences. Harpal from London in the UK has asked, what rehabilitation would you recommend for others in this situation? It's very important, as I said, to connect families to brain injury units. And this is because The transition back to home from the hospital can be associated with a number of changes, and that can be not only in the physical changes such as problems with vision and hearing and speech and movement, but also problems with attention, memory, sometimes personality and behaviour, and fatigue. In adults, there may be issues with sexual drive and other sensory changes people report, such as changes in their sensation. It's very important that we monitor and assess for these changes and give support. So I strongly recommend that anyone who has had encephalitis be referred to a rehabilitation specialist at a brain injury unit, even if they appear well at discharge from hospital, because many of my colleagues in rehabilitation tell me that the consequences can appear silent, that there's no physical disability, but there can be long-term significant effects on some people's lives that need to be looked for by rigorous testing of brain function. So finally, the last question is, what is being done to educate GPs and neurologists about diagnosing encephalitis? And this is from Maureen. So Maureen, around the world, societies like the Encephalitis Society is trying to increase awareness and education through webinars such as this. We are also trying to disseminate our guidelines. We have come together jointly as international experts to put together best practice in recognising the condition, testing for the condition, and advising about management. These also have been adapted in each country for local use as well, so that there's practical advice to GPs as well. But importantly, we're trying to get the message out through our societies, including to general practitioners around the country. So that's the end of our questions today, but if you look into the bottom of your field on the webinar, you'll see a site where you can ask more questions as they occur to you, and these will be redirected to us at any time. So I just want to thank you for the opportunity to tell you about enterovirus encephalitis, and I particularly also want to thank not only the Encephalitis Society, my colleague Dr. Philip Britton, who works alongside me in investigating encephalitis, and all my colleagues around Australia, but also particularly to Hansi and his mother Evan, who came and told you their story today. Thank you.